Well, good afternoon, everyone. I am Dawndra Jones, and I am the Chief Nursing Officer, Vice President of Patient Care Services at UPMC Magee-Womens Hospital, and it is an honor for me to be here to moderate this session. Well, thank you. I must have some friends out there. You know, I've been with UPMC over 31 years, working as a newly licensed nurse to Chief Nursing Officer. Not only am I the Chief Nursing Officer at Magee, but I was the Chief Nursing Officer at UPMC East and UPMC McKeesport Hospital. There I got the honor and privilege to work with Dr. Conti in really leading a lot of our population health work. As I am born and raised in Pittsburgh, it is critical for me to ensure that people who look like me, my friends, my neighbors, my family, have access and receive the highest quality of care. So I was excited to be able to join the Magee team because I know there are people there, Dr. Edwards and Dr. Simhan and Dr. Gossman and Dr. Livingston, who are working diligently to eliminate health disparities in women's health and maternal health. I am also the immediate past president of Pittsburgh Black Nurses in Action, which is the local chapter of the National Black Nurses Association, and our mission is to achieve health equity for all. I have learned through the work that we have done that it takes collaboration with our community members, our policymakers, and our healthcare organizations to make sure that we achieve health equity. I want to thank Dr. Cooper Owens for her presentation about racism in healthcare and has taught us how we've gotten here and what was happening prior to our time being here. I also have to thank Dr. Danielson for having the courage to speak up for what was right and remind us of what the late Representative John Lewis statement that said, "Never be afraid to make some noise and get in good trouble, necessary trouble." So in this next session, we were going to be talking about transformative community partnerships, where we're going to hear from our community members, how we can create and sustain partnerships to improve the health care for all, so that all individuals can reach their most optimal state of health and wellness. I have learned that we have to take health care out of the brick and mortars of the hospital and bring it directly to where the people are in their community. So first, we will have a keynote presentation from Father Paul Abernathy, and then followed by that, we will have a panel discussion with some community organization leaders. So first, let me introduce Father Paul. Father Paul Abernathy is an Orthodox Christian priest and founding CEO of the Neighborhood Resiliency Project. He is also pastor of St. Moses Orthodox Church. Since 2011, Father Paul has pioneered the framework that facilitates the transformation of trauma-affected communities to resilient, healing, and healthy communities. This new model, trauma-informed community development, focuses on helping people be healthy enough to sustain opportunities and realize their potential. Community groups from across the nation have worked with Father Paul to be trained in the framework so that it can be replicated in other regions. In addition to his work with the Neighborhood Resilience Project, Father Paul serves on numerous community boards and committees. He has received many awards, including Eagle Scout, the New Pittsburgh Courier's Fab 40 Award, Larry Richards Hometown Hero Award, Pittsburgh Magazine 40 Under 40, the Wheeling Jesuit University Father Pedro Arupe Distinguished Alum Award. He holds a Master's in Public and International Affairs from the University of Pittsburgh, as well as a Master's of Divinity from St. Tikhon's Orthodox Theological Seminary. He is a former non-commissioned officer in the U.S. Army. Father Paul is a combat veteran of the Iraq War. So thank you for your service, and without further ado, I introduce to you Father Paul Abernathy.
distinguished brothers and sisters, it is good to be with you this afternoon. I come before you as a man who is not only moved by the powerful words we've heard this afternoon, but I come before you as a man who has been moved regularly by the encounters that I have had with men and women of goodwill across this healthcare system. Encounters that have inspired relationships that I would characterize first and foremost by love. When I received the invitation to come and be with you today, upon seeing who were the speakers, I was humbled, obviously. But beyond that, I was grateful. I was grateful for all of the love that I had experienced through those who in our time of trial in the community had called me frequently and said, "We remember you." Had said to me, "We want to do better." Who said, "Let us come together and forge a brighter future." So I believe that this is a day of great hope. We cannot discuss the issue of health inequity or racism in our healthcare system or racism in the United States of America today without taking account of what we've experienced over the past 18 months. 2020 was quite a year. The pandemic, the racial reckoning was quite a year. I've heard it described as overwhelming, challenging, difficult, painful. I've heard these words. But when I was reflecting on 2020 and the year it was, I was reminded actually of a story that comes from Thomas Edison. Thomas Edison, that great American inventor who on December the 10th, 1914, woke only to find that his factory, his beloved factory in West Orange, New Jersey, was ablaze. It was burning to the ground. And in an account that was given years later by his son Charles to the Reader's Digest, Thomas Edison was standing with his son Charles watching the blaze. And Thomas Edison said to his son, go and get your mother and tell her to bring her friends. They're never going to see a fire like this." That was his reaction. Of course, his son Charles didn't want to do that at all. He hesitated. Upon seeing his hesitation, Thomas Edison said to his son Charles, "It's all right. We just got rid of a lot of rubbish." When I reflect on the year 2020, that's the potential that really it has. We as a society have a lot of rubbish to get rid of. And I will tell you, it is sometimes not because of altruistic motive that we eradicate this rubbish from our lives or from our society, but sometimes this eradication is the result of crisis. Sometimes this eradication is the result of loss. Sometimes this eradication is the result of challenge. And so, brothers and sisters, some of what we heard here today has an opportunity to be burned out in the hour of crisis and replaced with initiatives and goodwill that lead to positive outcomes in our community. We can see examples where this rang true over the last year, certainly beginning with the vaccine hesitancy, we may say. It was a significant social challenge to consider how we would vaccinate our population. And here, brothers and sisters, may we say it became so evident when it is indeed the sum of all of us that matters. We understood at that particular time, if we had one portion of our population that got vaccinated and another portion of our population that refused the vaccine, it would undermine the safety of our entire society. And so this question about what happens to the least of us, it affects all of us. It was not a question for us because we understood it, because our lives were at risk. And yet, with that, with that dilemma, new relationships were formed. We understood that there's no way that we are going to be able to vaccinate all our society without the participation of our society. Public health, I watched, was transformed from a concept that was relegated to mere clinical interventions to a reality that played itself out on the streets of our communities. Public health, I saw transformed from the primary responsibility of physicians and clinicians to the primary responsibility of grandmothers and uncles and aunts who were committed to helping roll this vaccine out in their communities. If we have gone through this experience together as a community, we cannot go back. This was done in the face of this extraordinarily painful history of medical abuse, of racism in the healthcare system. We demonstrated that we can hash things out to the point of action in a time of crisis. Of course, my only concern is that as we have increased vaccination rates and the racial reckoning of 2020 gets further behind us, that so too does our commitment to one another to reorient ourselves and understand in new ways what it means to engage in initiatives that result in equitable health care for our communities. So we have to do things differently. Now sometimes, as we've heard already this afternoon, we are so committed to doing things just the way we've always done it. Just last night, there was a gentleman who was telling me a story of a young woman who watched her mother. He watched her mother every Christmas. She would have this ham she would set on the table, and she would slice the front and she would slice the back of the ham. She did this every year. One Christmas, her daughter asked her, "Mom, why do you slice those two sides off the ham?" And her answer was, "Well, because my mother did it." Just so happened that her mother, now grandma, was sitting also at the table. So the young girl said, "Why did you slice those two sides off the ham?" And she said, "Well, because it didn't fit in my pan." And you know, there are so many practices that we do simply because it doesn't fit in the pan. Well, maybe we have a larger pan now. And maybe we need to rethink about how we're doing things. And maybe we need to be honest about old practices and, dare I say, old processes. Sometimes it's not just the practice, sometimes it's the process. You know, I've witnessed many, many community meetings that are fruitless. They produce no positive outcome. And when I think about the reason why that is, I think the way in which the meeting was executed was flawed. I think the way in which community members were engaged leading up to the meeting was not sufficient. I think about the lack of information that all parties involved in the conversation, the lack of information of all parties involved in the conversation undermined real progress. I think of all of it, and I think the process was flawed. What does it look like to have a process wherein problem solving becomes a broader responsibility for our communities, where we're not only asking UPMC to solve the health problems among us, but that there's room for people, average community members, to offer solutions. It's come up already, the brilliance that resides in our communities. I will tell you, brothers and sisters, there is a high degree of brilliance in our communities. Do you know the highest rate of entrepreneurs per capita in the United States is in the African American community? I asked one young man who works for us, "Why do you think that is?" He said, "Because we have to do a whole lot with just a little." This innovation that is alive, you know, these areas of the community where we have where the death gap is, where we have a lower life expectancy. Do you know these areas of the community where there are like these high rates of gun violence? Do you know these these areas of the community where we have high rates of gun violence. These are the parts of the community where we have high rates of enterprise, where we have high rates of ingenuity, where we have high rates of creativity, where we have abundant love. I want to tell you something. There are so many people talk about resources sometimes. They cloud conversations. I've seen people who are so driven by love. They have chosen poverty. They have chosen poverty just so they could have the privilege of serving their brother or sister. They've proven their purity. And sometimes we doubt it. There are answers to be found there. This is not exclusive to the conversation around health equity. Corporate America, the private sector, is learning quickly the value of crowdsourcing solutions. The value of crowdsourcing solutions. They're learning quickly. Some of you may remember Netflix some years ago. They offered $1 million cash prize. They wanted an algorithm. They wanted an answer. They wanted to figure out how their movie selecting algorithm could improve. So they opened it up. They had their experts. They had people who obviously were developers, people who could create their own algorithms, but they knew that there were more ideas that were out there. So they opened it up. $1 million cash prize. $1 million cash prize for anyone who produces an algorithm that improves the performance of this application. They received 44,000 ideas. 44,000 ideas. Now, brothers and sisters, 30,000 of those ideas actually were lower performing than the algorithm they had. But here's the real story. 14,000 of those ideas were a potential. The winning idea improved their performance by 10%. What does this look like when we apply it on these issues of health equity? What does it look like when we apply it to these health challenges that reside in our communities? And may we say, and it's already been said, that there are so many. We look at health outcomes in a clinical setting. We look at health outcomes in a clinical setting. It didn't start in a clinical setting. It's been covered here. There are these community drivers. We talk about the correlation between redlining and the COVID mortality rates. We talk about the correlation between redlining and infant and maternal mortality. We understand that certainly there is an impact, these drivers in the community. So we have to address these drivers at a community level. What does it look like when we do crowdsourcing regarding these issues? Annie Rickers, Cincinnati, Ohio, went off to Harvard Business School. Came home, though, to Cincinnati. She had a love for Cincinnati. At that particular time, when she came home to Cincinnati, they were facing the opioid crisis. Maybe this will be a good digression to talk about racism as it relates to drug use. Because I'll tell you, people talk about the opioid epidemic, but I never really heard people talk about the crack epidemic. People say, well, when drugs hit this community, it's a public health issue, but when drugs hit this community, it's a criminal justice issue. This is our reality. Nonetheless, opioid crisis, the city of Cincinnati opioid crisis. So she understands that there's a lot of the private sector that is turned on to this idea of crowdsourcing, that there's a lot of ideas out there. How do we engage them? And so she says, why don't we host a hackathon about this opioid crisis? There were teams that submitted. Of course, they offered some kind of prize. Teams that submitted for the opportunity to try and see who could make some progress, who could come up with some solution as it relates to the opioid crisis. What resulted was a new company. A new company emerged. 3 years after the hackathon was still running. It had made a significant improvement as it relates to the products and services that were available to address the opioid crisis. It was a platform that developed real-time treatment capacity information to patients in need as well as providers. And what's more, as it was being used. People were beginning to understand that there was this idea that came out of this hackathon that was now making progress as related to a public health concern. So here's what we have to understand. When we engage the community, it mustn't simply be because we just think it's the right thing to do. Yes, it is the right thing to do. Let us also, though, understand that in engaging the community, there is extraordinary value that cannot be found in institutions that have been in and too close to the problem for too long. Sometimes we need a fresh perspective, and our communities offer that fresh perspective. There's an example of this that happened in even my experience with UPMC some years ago. A team from UPMC came and engaged me on this question of gun violence. Now, I've been in this space. I've been part of these conversations for some years. What do we do about gun violence? And one of the things I find so challenging is that when somebody talks about gun violence and they say, this is the solution. It's a complex issue. There are many problems that drive it. It requires a multidisciplinary approach. It requires engagement on many levels from many different people, stakeholders, and systems. It's a complex issue. And I remember whenever a team from UPMC engaged me on this, just asking, is there something that can be done on gun violence? And it just so happened that at that time, there was a group of community members who were dreaming big. There was this vision about how there could be a multidisciplinary, collaborative approach to disrupt the gun violence in our communities. There was this dream that what if we could create collaboratives in which we could pull some of the best experts in particular fields together with community members who also had an affinity for a particular topic with lived experience and strong community relationships. And what if those collaboratives could coordinate themselves with other collaboratives to the end of creating fundable projects that produce measurable outcomes? What if we could do that? All of a sudden, this contact with UPMC gave this community vision potential. And people were talking about, we will have a public health collaborative. Can you imagine this? Where we have docs who oversee particular areas of, let's say, maternal health, working alongside of mothers in the community to understand what were the drivers and how we could disrupt those drivers, to understand what were the protective factors and how we could bolster those protective factors. We talked about a public health collaborative. We talked about housing and economic development, because certainly we can't talk about a health without talking about healthy housing. We talked about education. What happens in our schools affects the health not only of our children, but also of our parents, of our families. We talked about research. Do you know, people are talking about research. I always hear people talking about research. And you know, I am a proponent of research. I am a proponent of research. Research is important. Research is valuable. But here's where research fails. Research fails when it sits on a shelf. I'll never forget my bishop. I said, well, I asked him when I was in seminary if I could get his blessing to do a thesis. I thought he was going to like the topic I selected. I asked him for the blessing, and he just put his finger in my face. He's from Patterson, New Jersey. He put his finger in my face. He said, you got my blessing, but it better not just sit on a shelf. And you think the thing is, there's too much research sitting on a shelf. How do we create collaboratives where we leverage research to improve the quality of life in our community? And in this way, research becomes mutually beneficial. We can talk about technology and innovation. We need a way to help community members become analysts. You know, we have the RAND Corporation come into our community from time to time. They do these health studies. And it takes hundreds of thousands of dollars, and it takes years. But what if we took algorithms and mobile apps and equipped community members with the ability, with the touch of a button, to understand and assess community health? What if we had the ability to help the average community member become an analyst by way of technology? Can you imagine if we bring some of these web developers from Google together with some of our ingenious minds, our young minds in the Hill and Homewood and Lincoln Larimer? And let us not forget the importance of training together, learning how to lead together. It is very clear that leadership development is necessary. Every organization goes through leadership development. One gentleman said to me not long ago, he said, when I'm looking at the leadership development in our organization, a large corporation, he said, it's very clear to me that we are very good at developing leaders in our organization to be leaders in that organization. But I don't believe we're giving any attention to how we develop leaders in that organization to be leaders for the whole community. We have to understand that whenever we rise, I can say this, I'm a priest, I'm a pastor. When I walk into that neighborhood, I understood from day one that I just cannot be the pastor of this parish. Because from day one, I, whether I like it or not, am a community leader. It is no different for those who ascend to positions of leadership in healthcare organizations. They are now community leaders. And yet we haven't always given the attention to developing that aspect of leadership, whereas we could. Just as in the community, we haven't given much attention to developing leadership that understands how to interact with systems, how to interact and leverage institutions, how to build successful collaborations with organizations that have resources. So this idea of a collaborative that focuses on training and leadership development is very important. And finally, finance and executive support. A lot of times what we have is heart in the community, but heart doesn't balance the books. Sometimes we need that business acumen that can really support, that can really help advance the work. Sometimes that infrastructure that people often, I'll tell you, I've seen this many times. People, they want to say there's a woman who'd be a successful baker in the community. And what she loves to do is she loves to bake. And people are saying they're trying to make an accountant out of her. Why not give her an accountant so that she can do what she loves to do and build that successful business? We understood that real change is possible. Now, COVID, what we didn't understand when we were having this conversation is that we were just a few short months away from COVID happening. But it was a glimpse. What if? It's the question that remains on my heart to this very moment. What if? What if we were able to demonstrate that kind of collaboration? What if we were able to grab the renaissance that's gripping Pittsburgh and redefine it? Not a renaissance that's measured by the number of businesses per se or the amount of financial investment, but a renaissance that's measured by the health and well-being of our region. If these become the primary measures, brothers and sisters, then real change is possible, because I believe that we achieve what we measure. And I will tell you, I believe very strongly we are measuring the wrong thing. But this change in terms of how we achieve, how we understand success, if we are to think of it in terms of health and well-being, that change will not be catalyzed anywhere other than in the healthcare system. Who else would come forward and say, we want the death gap to be a measure of success than those that are measuring the death gap? Who other than someone who is experiencing the asthma rates among our children in the hospitals to come forward and say it matters about the rate of asthma in our populations? Who else than to deal with the maternal mortality rate in close and personal than to speak and say this has to be the measure of success in our community? UPMC has an opportunity not just to define itself by having these practices that reinforce and produce equitable health outcomes, but UPMC has the opportunity to lead a region that is going through a rebirth, a renaissance, at a time in this nation where people are seeking answers to the painful history that is the reality we have inherited. Certainly it requires trust. And I will tell you, we can't talk about trustworthiness without talking also about demonstrated trustworthiness. Here's what I mean by that. When I first began my ministry in the community, this woman says, you know, these young priests, young ministers, young preachers come through the neighborhood. This woman says, oh, you're here to do something nice. I'm so happy about that, because my niece and her 4 children don't have any beds. And since you're here to do something nice, you ought to do something nice for them. Well, I understood she was giving me an opportunity. The opportunity was to get her beds. Get them 4 beds, because it's one thing to say I hear you, but it's a whole different thing to show that I hear you. And in this way, that resource becomes demonstrated trustworthiness. Don't just take my word, watch my actions. Brothers and sisters, where will we be in 5 years? This is the question that's before us now. 5 years from now, we'll look back on Advocacy Day 2021, and we will remember it a particular way. Maybe we'll remember it as a fond reunion or encounter with new friends. Maybe we'll remember it as some compelling discussions and some frustrating realizations. Maybe we'll remember it as a season of hope that ended in failure. But maybe, just maybe, we'll remember it as the day that a new future was forged. Maybe, just maybe, we'll remember it as the day in which community members came together with clinicians and administrators to the common end of producing a healthier community for all of our brothers and sisters. Maybe this will be remembered as the day in which we not only redefined ourselves as community members or an organization, but as a region that redefined itself, that lit a fire that burned across our nation from sea to shining sea and catalyzed a season of health, a season of healing, a season of resilience, a season of justice, brothers and sisters. And maybe that begins right here in this room. Maybe that begins right here today. Maybe that begins right here with the choices that we make. Where will we be in 5 years? What would it mean if we accepted our role as leadership and pulled together other corporate partners to join in this? What would it mean if we community members reached out across neighborhood boundaries to our stakeholders and leaders to join us in this effort? What would it mean? So with this, let us leave with the following reflection. We're talking about 5 years. That's what we talk about in America, 5 years. 3 to 5 year plan is what they say. The Iroquois Confederation, these 6 tribes of the Iroquois that came together to the Great Law of Peace, and it's a very profound document. In fact, it informs to a degree our Constitution of the United States, the Great Law of Peace. And in it, the Iroquois, they say that before we make any decision, this is how we'll have peace with each other, they say. How will these tribes have peace with each other? Before we make any decision, we will ask how this decision affects the 7th generation. What we're doing here today is not just about us. It's not just about our children or our children's children. But I tell you this, 7 generations from now, what we do here today, it will affect them. What will they say of us? Will we be in slideshow presentations about our sins? Or will they raise their eyes to the heavens and thank the God above for righteous ancestors who were courageous, who were loving, who were forgiving, who were persevering, who looked beyond their own interests to the interest of generations long unknown? Who will we be to them? This is the question. I thank you for the opportunity to be with you here this afternoon, and I pray that this conversation, that this effort, that these relationships produce a future defined by love, hope, and health. Thank you. May God bless you. Okay. Sure.
I don't know about you, but I'm ready to say amen, right? So if I can ask the panelists to please come up to the stage. So thank you all. So I think it's really important that our audience knows about you all's organizations that you represent. So if I could ask you to please introduce yourself and talk about the mission of your organization, please. Who wants to start?
I will start.
Okay.
My name is Victoria Goings. I am the Vice President of Programs and Services with the Urban League of Greater Pittsburgh. Our mission is to provide an avenue for people of color and those of low income to be able to move to places of self-sufficiency.
Great, thank you.
Good afternoon. I'm Trish Gadsden. I'm the Chief Executive Officer for Macedonia Family and Community Enrichment Center, or Macedonia FACE. We are a community-based social service organization that was originally created as an outreach ministry of Macedonia Church of Pittsburgh. We have grown to become an independent human service organization that has a historic and cultural connection to the Hill District, but we have a county-wide footprint in all of Allegheny County, and our mission is to encourage the development of healthy families. Our vision is that all people are living in healthy and thriving communities, and that speaks to the tenet of racial equity, which is integrated into the modality of the service structure that we employ.
Thank you.
My name is Carolyn Rychek. I'm the coordinator for the Pittsburgh Public Schools Teen Parenting Program. There has been a teen parenting program in existence with the Pittsburgh Public School District since the 1970s. In the 1990s, a new collaboration occurred with the Department of Human Services and Pennsylvania Department of Education. Our goal is to break the cycle of welfare, make sure the students stay in school, get a diploma, get the prenatal care, the parenting skills, and the postnatal care, and we're actually able to work with them for up to 210 days after they graduate to ensure that they either get a job, post-secondary education, and housing. But we also work with them on postponing secondary pregnancies.
Thank you. Dr. Swayze.
And I'm Dan Swayze, the Vice President for Community Services for the UPMC Health Plan. We are an organization that is desperate to change the status quo, among other things.
Well, great. Well, thank you all. So, you know, as we have learned a lot today and heard a lot from the previous presenters, one of the things that truly come to mind for me is when we talk about the workforce, and I've heard from several of the speakers about the workforce and what we need to be doing in our workforce. Carolyn, can you share with us, like, you know, how do you think that we can have our workforce really try to meet the needs of the individuals that you serve?
Well, I've been doing this for 20 years, and when I first started, we had an excellent relationship with Magee. All of the teen parents would go to one specific unit. It was the gray unit and then the yellow unit, where they were really able to work with our students on the level that they needed them to. When I first started, it was very strong, and as we progressed, people retired and we lost that relationship to the point we had students that just didn't know what the medical terms were. They were being spoken to as if they were adults and they were 12. I would love to reconnect to make sure that we have that collaboration, that consistent collaboration that doesn't just end when someone retires, to be able to have that relationship where I can work with them and we can try to work together to do the best for our students. That would include, though, doing more around informed trauma and implicit bias, and really making sure that we're meeting the students where they need to be met.
Thank you. And when I think about, you know, Dr. Cooper Owens' presentation on history and the rich history in Pittsburgh, especially with emergency medicine, as I smile and look at you, Dr. Swayze, can you share us a little bit about what you all are doing based off of that history and what we're looking at for our UPMC workforce?
Sure. So for those that aren't familiar with the history of Pittsburgh, in emergency medical services, we have something to really be proud of, and that is the work that was done in the Hill District. The quality of care that's delivered on an ambulance today was started by pioneers that came from the Hill District. The first time that people were intubated or defibrillated out of a hospital setting was in the Hill District. And there was an ambulance service called Freedom House at the time. It was a community-based organization that was involved with food delivery and a lot of other community-type activities that really provided a strong foundation, a workforce for us as UPMC to train them to do things at the time that were only done in a hospital setting, even things like CPR. I have a copy of their textbook, and it said CPR was closed chest compressions for physician use only. And we were teaching people in the Hill District how to do that at a time when the civil unrest in the 1960s was incredibly high, and with a population of students in that program that self-identify today, those that are still around, as society's disposables. People at the time that were considered to be unemployable, and yet UPMC had visionary people like Dr. Peter Saffer and Dr. Phil Halen that went into those communities and said, I think we can train these gentlemen to provide critical care services in an out-of-hospital environment and really change the nature of the way that we as a country address these emergencies and improve the quality of life, the quantity of life that we live by improving survival rates out there. That legacy is forgotten a lot because what happened next was racism. The city decided that it wanted to expand these ambulance services. There was one particular case outside of the service area of Freedom House, which was confined to the Hill District. A child had been hit by a bus. And at the time, outside of Freedom House's catchment area, you got a police paddy wagon that would come and take care of them. And the police officer got on the radio for that particular call and said, I want the Freedom House medics to come. And the dispatcher said, I'm sorry, that's out of their service area. It happened to be in Squirrel Hill. And he said, I don't care. I want them here because they're the only ones I trust to take care of this kid and his injuries. And that really sparked the city's desire to have an ambulance service. So they did the unimaginable. They dismissed the Freedom House medics. They hired white firefighters from the suburbs to come in and provide care that they had never provided before and called it an ambulance service. They hired the Freedom House medics on as the first medics in the city's ambulance service and then promptly fired them all for a variety of different issues. What we're trying to do today is build on that legacy. What you don't understand about the nature of 911 in the 1960s was that when people called for an emergency, they were having a medical emergency, they were hit by a bus, they were having a heart attack, they were shot, there was something emergent about that. Most of the calls to 911 today are the result of somebody who's in a crisis, but not a medical crisis. I'm hungry, I'm lonely, I'm scared about my housing, I don't know who else to call, and what we've developed in our 911 system is the most accessible, but most expensive and least effective way for dealing with issues and crises and social determinants of health. And so what we're trying to do today is build on the legacy of Freedom House by including in that original EMT training, how do I address social determinant of health crisis? How do I help people in those moments of needs by not just trying to drive them to the emergency department or providing emergency medical care? How do I get them connected to the right system of care at the moment when they need that help the most? And we've had some very promising results. We're graduating actually this week our third cohort of students, and I'm very happy to say, thanks to partnerships like our Neighborhood Resilience Project partnership with Father Paul's group, the students in these programs don't look like me. They're African American women, most of whom, 80% of whom, have been hired by UPMC in different healthcare roles. This, I hope, is the foundation of something that is scalable to other communities as we take a similar approach to the way that we've reached out to our community partners to help us recruit, the way that we've embedded trauma-informed care in the classroom setting itself, not just to teach them how to deal with patients that they're going to deal with on a 911 call, but how to manage the traumas that they've experienced in their lives. That's going to make them more academically successful, more successful in their professional career. We've really done a great job at collaborating with a bunch of different system partners to make these students successful in these roles in what I hope we can scale up in a much larger way.
Thank you. And so when we speak about brilliance, though, and brilliance in the community, and I think about Macedonia and what you guys are doing there, can you share with us, Ms. Getson, what are some of those things that you're doing to improve the care of the underserved communities, and how do you position or would like to see us to help?
I think that's a good question. I appreciate Dan acknowledging the contributions of the residents of the Hill District and making a difference in community approach to needs. I think that we need to continue to acknowledge and understand the history and the contribution of community. From our perspective, we look at things from a holistic approach as we talk about how to dismantle the impact of racism when we are looking at delivering services to consumers. So that begins with, of course, responding to initial needs, the food insecurity, the housing insecurity. But it's also important to be engaged in meaningful and in meaningful and impactful ways, conversations around policy that lead to the conditions of food and housing insecurity that we see. So what that means for us is to be informed, to know the history, and to have conversations in our white spaces around the policies that continue to manifest the gentrification of neighborhoods, the under-resourced communities communities where there is not access to fresh food and produce that leads to other health conditions that make the African American or other Black and brown communities more susceptible to the impact of COVID and a lack of resources. So what I would say is that for us, what we do is we focus on service delivery. That is one tier. We also focus on the way that we integrate racial equity into the day-to-day operations of our organization. So as the CEO, my organization is Black-led, but that doesn't mean that all of my staff look like me, have the same orientation as me. However, we are engaged in meaningful conversation about what equity looks like, what racism looks like, the impact that it has on the day-to-day life of the people we serve, and how we dismantle that, and how we're intentional about the way we engage in services, and are specific about the way that families encounter institutions and systems. And then most importantly, we talk about policy, and we talk about the impact of policy in the way that services can continue, the way that access to affordable housing can impact on families, the way that resources that enable repairs to families who have housing, what that looks like. We talk about livable wages and living wages, and what that can mean to families as they're, talking about that. And the one last point that I'll make, Dawndra, because I could go on and on, but the one last point that I'll say is that services are important. I don't want to diminish that, but what we really have to talk about is the fact that women who look like me, Black women with a PhD, are 3 times more likely to die when giving birth in this city and around this country. And so those are the things, and the way that you dismantle that is not through charity, it's not through services alone, it is through policy on hiring, policy on training, policy on the dissemination of resources. And those are the ways that we really try to show up in conversations like these.
Thank you. And again, even more brilliant, looking at the Urban League and what is the Urban League doing surrounding health equity?
The Urban League has been here in the city for 103 years. As COVID unleashed the disparities of health, particularly in our communities, we have embraced what we call a One Pittsburgh Now initiative. And in that initiative, we target the Hill District, the Homewood area, North Side, as well as Mon Valley, to provide training avenues on varying health issues. One being, of course, the importance of the COVID vaccine. So we are out in the forefront doing outreach in those 4 targeted neighborhoods and beyond, with the informing people about the importance of the vaccination. Part of our departmental structure is family stabilization, family child growth institutions. So we do have family support centers. Those family support centers are in 3 key areas across the city, and we provide information to those individuals as it relates to health initiatives, as it relates to the sustaining of the family unit, as it relates to training opportunities. I'm proud to say with you, Dan, UPMC, we've been able to provide individuals in that training program, most recently at Duquesne for EMT training. So just as someone said in the, in the panel before us, it starts with training people, training those health and those family members that you can live sustainably, equally, equitably, and make a difference for you and generational wealth to come.
Well, thank you. And, you know, I want to thank you all. I know we only have like 5 seconds left, but I do want to ask, you know, if you could just briefly say, if you had an ask, what would that ask be?
The ask would be the continued collaborations with UPMC. It's critical. It's critical in stabilizing people moving forward. The training is critical. People want self-sustainable wage jobs. They want to be able to break out of poverty. They want access to health care. When we are in lower paying positions, we don't have access to health care. So provide the avenue, the access for us to have those opportunities equally.
Thank you, Ms. Gatson.
I would say that my ask would be that these conversations move beyond this room and that it is escalated to a point that moves beyond a level of awareness. I think one of the keynotes talked about it earlier this afternoon in terms of translating these conversations from awareness to action and do so in measurable and accountable ways, so that when we're talking about race, we're not talking about just purely demographics to check a box on the form for reporting, for funding, or for state requirements, but that we're actually talking about race in a measurable way that enables us to lessen the likelihood that we can make a determination of someone's lifespan based on a zip code or based on their racial identity.
Thank you. Ms. Rycheck?
Along with the sustained relationship, respect for my students, training so that they get the quality care and they get the respect that they deserve.
Well, great. Well, I want to thank all of the panelists. Father Paul, thank you for your presentation, and thank you all.
Thank you.